into the acid-fast stain. First and foremost, what is the acid-fast stain? The acid-fast stain is a special staining technique. It's used to identify bacteria that have waxy cell walls, and these waxy cell walls are basically rich in mycolic acid, which makes them resistant to ordinary gram staining. The classic organisms which get acid-fast stain, which are acid-fast stain positive, include the Mycobacterium tuberculosis and the Mycobacterium leprae, and also some species of nocardia. So previously we saw that nocardia is weak acid fast staining, but it does stain the acid fast. Okay, the secret is the mycolic acid. The cell wall of Mycobacteria contain the peptidoglycan, arabinogalactin, and mycolic acid. Mycolic acids are like these very long fatty acids, and they're basically like a thick waxy coating, and that basically helps the staining of acid fast bacteria. Normally, once a bacterium is stained, acid alcohol can remove the dye, right? But acid fast bacteria do not lose the dye, even when washed with strong acid. Why? Because they have this thick wax coating. They're fast and resistant to decolorization by the acid. So we call them acid fast. Normal bacteria, the dye enters easily and the dye washes out easily. But for mycobacteria, the cell wall has this thick wax layer which has mycolic acid. So it traps the stain in this thick wax layer and the acid cannot remove it. The principle of acid fast staining is basically carbonyl fusion. This is the red dye. Whenever the carbonyl fusion, the red dye is applied and heat is applied, the heat melts the waxy layer and allows the dye penetration. Once inside, the dye becomes trapped in this waxy layer. When you apply this carbonyl fusion and you heat it gently, all cells become red. And when you decolorize it with acid alcohol, which is basically 3% hydrochloric acid and ethanol, what usually happens is in non-acid fast bacteria, the bacteria loses the dye and becomes colorless. But in acid fast bacteria, it keeps the red dye and it remains red because the mycolic acid prevents the dye removal. And then we have this counter stain that we apply, which is methylene blue, which is why you can see all this blue on the screen. So this blue is because of methylene blue. This is a counter stain. Sometimes we also use malachite green, but basically this it's blue or green, right? So the result is that the non-acid fast bacteria, since the dye has washed out, they take up the blue stain and appear blue. But the acid fast bacteria, they're already red, right? You can see these red acid fast bacteria here. Since they're already red, they stay red. They don't take the blue stain up, right? And that's how we see that the final appearance of acid fast bacteria is bright red or pink, and non-acid fast bacteria is blue, right? Now, for the Mycobacteria family, just a little bit of a heads up. Mycobacteria are basically gram positive like cell wall, but stain poorly with gram stain. So these mycobacteria are gram positive like, they have a cell wall like gram positive, but they stain very poorly with the gram stain. They're basically acid fast bacilli. They're slender red pink rods on the Z Nelson stain. You can see this here. And this basically you can see this here. These are basically acid fast bacilli. These pink rods, as you can see, why the acid fast. We said that they have the macolic acid, the waxy cell wall prevents decolorization by acid alcohol. Organisms that we studied, I just showed you, are Mycobacterium tuberculosis, Mycobacterium leprae. We even have this Mycobacterium avium intracellular. This causes disseminated disease in patients who have AIDS already. We have Mycobacterium marinum. This is basically aquarium granuloma. We'll come to it later. Then we have the Mycobacterium scrofulaceum, and this basically causes cervical lymphadenitis in children. Um, and then we look at some violence factors here. So violence factors, the first most important violence factor is the cord factor. The cord factor is the most important TB violence factor, causes bacteria to grow in it, right? This cord factor basically it's like an intertwined ropes, right? You can imagine the cord factor like an intertwined rope. And what happened is, since they intertwined ropes, it's basically known as serpentine cords, right? Because um, as as this roping mechanism. I can show you that here. This picture shows you the cording morphology. And what's the function of all this cording morphology or the serpentine cords, right? It basically prevents neutrophil migration, it activates macrophages and stimulates the TNF alpha release, which produces granulomas. This is why TB patients develop fever, night sweats, weight loss, because TNF alpha is the main culprit. So this serpentine cord mechanism basically prevents the neutrophil migration and activates the macrophages. This stimulates the TNF alpha release and produces granulomas. Right? This is the main reason why TB patients get the night sweats, the weight loss, because TNF alpha is your main culprit. Then we have the sulfatides. Now, the sulfatides, let me go ahead and show you. The sulfatides, what are they? They basically surface glycolipids and they inhibit phagolysosomal fusion. Now, a normal macrophage what happens in a normal macrophage, you have the macrophage which causes to create a phagosome, and then the lysosome participates in the bacterial killing, right? So that's the mechanism of a normal macrophage. But the TB blocks this. What the tuberculosis bacillus does is it takes the macrophage and phagosome and stops the lysosome from killing it. And this is happening through something called as these sulfatides. These are surface glycolipids, right? So TB basically blocks this lysosome in order for killing it. So there's no fusion, there's no killing, and the TB survives intracellularly, right? Transmission of TB basically happens through coughing, the airborne droplets. So a patient coughs, and another patient inhales those droplets, and the alveoli gets TB basically. Primary tuberculosis happens, something known as primary tuberculosis. It happens at the first exposure. It's usually on the lower or middle lung zones. And macrophages basically engulf these bacilli, and the immune system forms something known as the Gons focus. Right? The Gons focus is like the subpleural lesion when hilar lymph nodes are also involved. And the Gon focus is basically the Gon focus plus the hilar nodes is called the Gon complex. This is shown in this image here. This is the Gon complex. Here you can see that there's a Gon focus and there's hilar nodes, right? So this is like this happens when there's primary tuberculosis. You form the Gons complex. But what happens next in more than 90% of the patients, the immune system wins. The result is fibrosis, calcification, and latent infection. The patient becomes PPD positive. That's the test that we do to see if there's ever been an exposure of tuberculosis for a patient, right? And then there's something called as reactivation of secondary TB. Before going to the reactivation of secondary TB, I would like to show you a gone focus image before getting onto it. So this is basically the GONS focus. You can see the GON complex. The GON complex is basically when there is a GON focus plus it's in the hilar lymph nodes. When they both together, we call it the GON complex. You can see this central caseous necrosis, the epithelioid macrophages are all surrounding it, the lymphocytes. We have multinucleated giant cells here, right? And this is basically another image. This is an actual microscope image. You can see the granuloma. These are basically aggregates of epithelioid cells, epithelioid macrophages or cells with plumped, elongated nuclei and abundant cytoplasm. This is the necrosis center, right? And this is basically, this margin is showing you the necrotizing granuloma area. You can see lymphocytes here, epithelioid histiocytes, which are basically activated macrophages. These are the Langerhans giant cells. Can you see these giant cells here? They're characteristically present in Mycobacterium tuberculosis. So these are the Langerhans giant cells here. We also call them multinucleated giant cells because you can say there's so many nuclei present here. So that's something I want to show you. Okay, now we have something called as the deactivation, which is basically secondary tuberculosis. This occurs years later. It occurs with HIV, steroids, diabetes, malnutrition, or old age, and typically affects the upper lobes. So it's important to know that the primary TB usually affects the middle and lower lobes, and later on, your secondary TB basically affects the upper lobes. You can see that here. So this is a picture of the Mycobacterium tuberculosis. Here you have the highlight nodes and gone focus. Together we call it the gone complex. In 10% patients, you have this basically not in 10% patients, basically the primary tuberculosis is when you get it in the middle or lower lung zones, right? So you can see this is in the middle or lower lung zones. right? The gone focus. And now, in 90% patients, this gone focus is healed by fibrosis calcification, and these patients become PPD positive, the purified protein derivative test positive, right? So basically, been one exposure to TB. But in 10% patients, this progresses, this becomes progressive primary tuberculosis. This happens in patients who have AIDS and malnutrition, right? So it becomes a progressive lung disease. This is in patients where the primary tuberculosis does not get healed by fibrosis and calcification. But in patients who do get healed by fibrosis and calcification, years later, due to HIV, steroids, diabetes, malnutrition, or old age, if the TB reactivates itself, it typically affects the upper lobes, right? So you can see it's affecting the upper lobes here. Why the upper lobes? Because TB loves oxygen, and upper lobes of your lungs have highest oxygen tension. It produces caseation, necrosis in the cavity. It becomes like this cavitatory lesion, and the result is basically this fibrocaseous cavitary lesion, as you can see here. So this is that fibrocaseous cavitary lesion in the upper lobe. Now, symptoms of classic secondary TB include fever, night sweats, weight loss, hemoptysis, and chronic cough, right? I'll punch it here. TB is basically a wasting disease, right? So you get these fever, night sweats, you get weight loss, and chronic cough. You can think of it as this wasting disease. And later on, you get these granuloma formation, right? The hallmark lesion of TB is a granuloma formation. They basically have macrophages inside it, lymphocytes, Langerhans giant cells, and caseation. And I showed you this granuloma formation on this image basically here. So that's where you get these granuloma. That's basically aggregates of epithelial cells, activated macrophages, and these Langerhans giant cells, epithelioid histiocytes, and so on, right? That's like the hallmark of TB disease, right? Um, Moving on, the Langerhans giant cell, I showed you this blue arrow. Basically, this indicates this entire thing is your Langerhans giant cell. I'll just draw this for you here. So this entire area is a Langerhans giant cell, right? So it has all this multinucleated areas you can see here, right? All these multinucleated cells, and it looks like these nuclei are always around the edges, right? These multinucleated nuclear cells are always around the edges of the giant cell. You get caseous necrosis. Why is it called caseous? Because caseous means cheese-like. So it's like this cheese-like necrosis you can see. Why? Because this center becomes like this soft, white, crumbly center, and because the immune system destroys the infective tissue. Something called, we didn't cover this progressive primary tuberculosis. The progressive primary tuberculosis occurs mainly in AIDS and patients who have malnutrition, right? So their primary TB does not resolve with fibrosis and calcification. Instead, it becomes like this progressive primary TB with patients who have AIDS and malnutrition. Instead of containing the infection by fibrosis and calcification, it goes into the bloodstream. Since it goes into the bloodstream, you get bacteria. Yeah, and since it's in the bloodstream, it spreads to the whole body, right? So this is basically called miliary tuberculosis, right? Miliary means millet seed appearance. And TB spreads through the blood, it affects the liver. Here you can see it affects the liver, it affects the lungs, it affects the lymph nodes, it affects the spleen, adrenal glands, and joints and long bones, even the meninges, right? And if it spreads to the vertebrae, we call it the Pott's disease. Pott's disease is basically tuberculosis of the vertebrae. It causes vertebral destruction, which leads to kyphosis and neurological deficits. This is something that's very commonly tested in exams, so I'll punch it here for you. So Pott's disease is basically vertebral destruction, where you get this kyphosis and neurological defect, right? That's very high yield. Then you have the PPT test that we were calling here, this PPT positive. This is basically the tuberculin test, right? It's basically you inject this purified protein derivative, and if it's positive, it basically tells you what there's either been a past infection or the patient has had some kind of past exposure, um, or there has been like a BCG vaccine exposure, right? So we give BCG vaccine in Pakistan also. This is like if the test is positive, you get, there's either a current infection or a past exposure or a BCG vaccine. And the problem is that the BCG vaccine causes a lot of false positives, right? So there's another test that we do, which is basically the interferon gamma release assay. And this is more specific and it is not affected much by BCG vaccination. So that's why it has these fewer false positives. We do this interferon gamma assay release assay and it has fewer false positives, right? So PPD negative causes this um, important exam point is like the PPD negative causes, why would you get a PPD negative? In HIV, sarcoidosis, severe TB, or steroid therapy, you even though if the patient may have TB, you still get a false negative because there's no T cell response. Since there's no T cell response, the test would be negative, right? This is an important exam point. Okay, let's move on to leprosy. Now, leprosy is also known as the Hansen disease, right? It's caused by Mycobacterium leprae and characteristics. This is also an acid-fast bacillus and it likes cool temperatures. It cannot be cultured in vitro, right? It targets the skin, peripheral nerves, nose, and ears. That's very important to know. So basically, it affects the skin and superficial nerves, nose, and ears. It's like a glove and stocking pattern. There's loss of sensation slowly, and it cannot be grown in vitro. Why does it grow in cool areas? Because M. leprae grows best at 30 degrees Celsius, which is a low temperature area. Therefore, it attacks the superficial skin because these are at a lower temperatures, the fingers, toes, nose, ears. It doesn't affect the deep organs, it affects the superficial skin. A clinical clue would be loss of sensation. It's like a glove distribution, a stock distribution. Patient burns or gets like finger injuries without noticing, right? That's how you know it's started. There's loss of sensation, there's a glove distribution, a stocking distribution. The patient burns or injures fingers without noticing. A classic example would be a reservoir. It's armadillos. So armadillos are classic reservoirs of Mycobacterium leprae. Now you have two forms of leprosy. There's a lepromatous form and there's a tuberculoid form, right? So if a patient if you have strong immunity, the patient gets tuberculoid form, and if the patient has weak immunity, he gets the lepromatous form. The tuberculoid form basically has a strong Th1 response, right? There's a very largely strong Th1 response, and features include few lesions, hypopigmented patches, and sensory loss, hair loss, and few organisms, right? So immune system basically controls the disease when there's tuberculoid leprosy. That is something that you should know. So whenever you get this tuberculoid type leprosy, there's a strong Th1 response, there's fluid lesions, hypopigmented patches, hair loss, sensory loss, few organisms, right? But the lepromatous leprosy, the one we've mentioned above, this is basically when the immune system is weak, right? This is when the immune system is weak and it presents diffusely over the skin with line-like faces. So you can see the line-like faces here. There are numerous lesions. There's a diffuse skin involvement. The bacterial load is massive. It's highly infectious, and you get these line-like line-like faces. Image B shows this. We saw this in image B here. There's thick skin, there's nodules, there's facial folds, the face resembles like a lion. It's very it's very upsetting when a patient gets this, there's a lot of like mental impact on the patient who suffers from this. It's honestly a very sad disease. In the olden days, people used to think that it's extremely contagious and you shouldn't live with these people, so they used to send them off to live in far areas and just let them die there. But nowadays, alhamdulillah, we have a lot of research and treatment going on for this. And the treatment is basically dapsone and rifampin for the tuberculoid form, and this clofazimine is added for the lepromatous form. Now you have these treatments for the leprosy, and they're very good. People live a fairly good life with it. So that's something to know. I'll stop here.